welcome to this session. It's the third clinical research session. The first of which is from Katharina Gaertner, who for 7 years worked at the University of Bern in the Institute of Complementary and Integrative Medicine there in Bern in Switzerland.
Thank you for the nice introduction, and thanks to the scientific board that I can speak here again. Actually, it was 5 years ago when I was asked by my former professor, Michael Frass, to summarize some meta-analysis in specific medical disciplines on homeopathic research done by his students. So I looked at the data and I found, different inclusion criteria all over. They have done something, applied for funding, and I tried to start it all over again from a clinical perspective. Last year I presented most of my methods, and this year I'm going to do something unconventional so that you can follow me why I chose the approach I'm going to present. So my questions are from clinical practice, and that's why I'm going to start with a clinical case of mine at a university-affiliated clinic. So this is a 65-year-old male, 2 days post a knee replacement therapy. He's known for hypertension, coronary heart disease, obesity, diabetes, what they usually have. But in his anamnesis it says also maybe he may have an epilepsy. He's already on an epileptic drug, and he also has a history of depression. So the situation is the nurse calls me and says, we need a doctor immediately. Patient is cramping and he's complaining of headache and I need to come. So I'm coming. He is slight hypertensive, but he has a normal pulse. Oxygen situation is good. He has no fever. He's awake, cooperative, in between fits. And he says, I have such a headache. And then he starts cramping, ophistotonus, there's torsion in the face. And the cramps are always starting on the right hand. So what we are going to do? Is there any evidence for what I can do? Because my evaluation would be, this is not an epileptic fit. Usually an epileptic fit doesn't close the eyes and has no targeted movement, right? But he's complaining of a headache. So what I need to sort out that there is no cerebral venous thrombosis, there is no cerebral vascular event whatsoever. So I need him to take him to a CT scan. Problem is he's cramping, he's whatever he's doing, very vivid. So the first choice for me is, okay, I need a kind of sedation to bring him to a CT scan. We brought him there, CT scan was fine. So our diagnosis, was discussing with my colleagues, is this is a psychogenic, non-epileptic seizure, most probably. We have no pathology, and it's not, the clinic doesn't point to an epileptic fit. The guidelines for this is, okay, on long term we need psychological intervention, but what do we do with the acute situation? It's not mentioned at all. So you have to decide on yourself, whatever is the clinic. And the patient is still cramping and has his headaches. So he was transferred I think it was on the other slide, he was transferred to the intermediate care unit, still with Bowley of the sedative medicament, with the sedative drug, but still cramping whenever the drug effect was subsiding. And I was asking myself, can I do something? Is this a clinical picture for a remedy? And I mean, you don't have seen the patient, but it's like cramps with the right hand and distortion of the face and headaches was for me cubrum. And he received it, 200, I'm sorry, the potency is missing. And the cause of the event was really that eventually he stopped cramping, although we gave no more disoprivan and he could be transferred back to the ward. So my conclusion from this is, often what we have from evidence from randomized controlled trials is not really important to a doctor in clinics. But what is important are guidelines which overlook the whole body of evidence so that I have a guidance. This is why I said the new analysis, systematic review, or literature overview, my literature search pointed to the fact, can I have, or do I have, or the research question was, do I have an evidence base for effective homeopathic treatment in public health care? And this is not only me saying so, also guideline makers say, okay, especially if there is scarce evidence for a particular condition, we should include more evidence and not only randomized controlled trials, but see at cohort studies and maybe even further down if there is no evidence in a higher hierarchy of the study design. And they say you should specifically not only focus on a condition, but on outcome level, what do I have, and ask the evidence for this, and then do really have a certain parameter so I can explain them quickly. Consistency, you see the effects, the estimated effects of the individual studies go in the same direction. Directness would mean that I have a clinical relevant outcome parameter, and that I at best have head-to-head trial with usual care. And precision is that I come to a precise conclusion for a specific population and intervention. The last part is from GRADE. They summarize evidence for clinical practice guidelines or have recommendations. So this is where I started with those ideas. And I now, last year the methods, this year we have the data extraction ready. What we are going to do with it in future, we have started some projects on condition-specific evidence. So what we found is that between 1980 and 2019, we have 631 controlled studies in 209 specific conditions. 2/3 of it is RCTs, a little bit more than a half is placebo-controlled, and around a half is peer-reviewed. Because what we did also, we looked for more evidence and also evidence from non-peer-reviewed journals. Around a quarter individualized, around a quarter routine prescriptions, and the rest mostly patents and complex medicines. But the most important is this here. So we have nearly 60 conditions where we have more than one controlled study for the same particular homeopathic intervention, meaning that if we have a closer look at those conditions and the studies within, that there might be an evidence base that it's not so bad than we ever thought. The table, it's going to be published quite soon. The manuscript is ready, but I need some formatting again. It's going to be an overview containing the conditions which include more than 2 trials, or more than 1 trial, at least 2, of the same intervention. The K1 would mean that this was really individualized because there are some other ideas like pre-selected remedies and everything we classified separately. And then here you have the design and the control, the sample size, if it was peer-reviewed or not. And this table will come up for all conditions. And I hope that this is a basis for future research to have a look at. Now it's there. There were observational studies. There were they chose this outcome. What was the effect, even if it was negative? What were the reasons? Maybe they also concluded something. So I hope that this will help also the homeopathic research community in the future. about the ADHD, we are thinking about doing a review, and most probably even with a meta-analysis. And we are working currently on, because that was a specific question of mine which I tried to answer with research. Arnica, in this case, pre-operatively given, has the following results concerning bleeding, pain, and edema. Left is favoring homeopathy, and right favors control. Red are the studies which were evaluated of high quality, not with the Cochrane tool, but with the tool concerning quantitative studies in general. And this is the work of a master medical student in Vienna. I don't know if we're going to publish this, but what I want to do is, or what we are currently working on, that we put in as well the studies which have given the arnica only after the operation. And with regression models, we are going, or hope, to see if the effect size changes when you give the arnica before, for which, before or after, for which type of operation you give the arnica. Does it have an effect, and what kind of? So I was always interested in that question, because everything is done in the homeopathy community, and maybe we have at least some answers. And this is already that I come to the end, how I come to the end. For further reviews, I suggest to look at a specific outcome and to look at the data which is already there for the condition you want to investigate, and focus on that. There are nearly 60 conditions which might be interesting to investigate, and we are working on it. I also think that these reviews can help to communicate this to stakeholders and say, see, for conventional therapy, for this condition, we don't have any good options. We might argue to enter guidelines as it is already done for palliative cancer care or fibromyalgia. So they surely but slowly, we can enter the international guidelines. I was quoting the Institute of Medicine guideline from the US, where it's in. Concerning quality, I want to just say a few words. Basically, in a review process, the quality should be assessed every time again when you're doing the review. And risk of bias, as I showed on the other slide, is only one parameter which needs to be present. Because if I have a methodological, very rigorous study, it can't tell me if it's really helpful for my patient in practice. For that, we need to evaluate other parameters as well. And we had just a workshop before this conference dealing with the question when it's good to combine data and what kind of quality tools should we use and in which way we should then combine and summarize it. And that was very exciting. Finally, I got the experts on the table, at least some of them. And we are also going to come up to give some suggestions out of that meeting in public. Thank you. That was it. Oh, I have to announce, I have to thank all the people supporting me in the work, the groups I work together with from India, Switzerland, and other countries. And we had also in the beginning some funding from the Homeopathy Foundation in Germany and the Tiedemann Stiftung.
Thank you, Katharina.